Good afternoon, everyone. Today is October the 25th, 2023, and it is 3:01 p.m. As the quorum of the committee is in attendance, I would like to call to order the meeting of the Central Health Ad Hoc Policy and Bylaws Committee. As a reminder, some of our committee members and members of the Board of Managers may also be participating by video conference, so the staff will be managing video and audio feeds of all participants closely to make sure we have a legally compliant meeting at all times. Apparently, we have no one who has signed up for public communication today, so we'll go straight to the agenda. Item number 1. Approve the minutes of the Central Health Board of Managers Ad Hoc Policy and Bylaws Committee for August the 19th, 2020. Do I have a motion?
So moved.
Dr. Bell makes the motion. Cynthia Brinson makes the second. All those in favor say aye.
Aye.
Opposed? Any abstentions? Motion passes. The second item, discuss and take appropriate action on potential revisions to the Central Health amended and restated bylaws. And on this item, Tralisha Brown and David Duncan of the Travis County Attorney's Office will be presenting. Okay, guys.
So, good afternoon, everyone. I am Tralisha Brown with the Travis County Attorney's Office, and you should have received a copy via email of an updated version of suggestions and recommendations that we're providing to you for the amended and restated bylaws. We don't have many major changes, but there are some things that we do want to bring to your attention. So you will note that, thank you, Brianna. You will note that in the definitions section under Commissioner's Court, we have an edit, and that's to capitalize the word members in that sentence. You will also note that there's a spacing error that we corrected in Medical Executive Board. Going to the next correction, the grammatical correction, program budget. Again, there is a spacing error. In addition to in Travis County, the definition of Travis County, there's a spacing error there between West Hills and portions. Moving on to section 3.0. There's that spacing error, thank you, Brianna. There's that spacing error between the word shall and the colon. And if we move on down to section 6.2, we corrected yet another spacing error. So as I stated before, there are the grammatical errors and spacing errors that we are correcting throughout, that we recommend that you correct. But then there's some other changes. So if you go to section 7.0, the Budget and Finance Committee, and that's in Article 7 under committees, the first one. There we go. What we recommended is that you remove the words "at least monthly" and replace those with necessary by the treasurer. And the reason that we're making this recommendation is because you haven't always met monthly, and you want to allow the treasurer to have that flexibility in making the determination as to how often you will need to meet. So that is one of the recommendations that we're making here. Additionally, if you go down to section 7.3, so section 7.3 is a new section and it is old to some of you. It was removed at one point, and now it's back in style. So here's the situation. In January of 2015, the Board of Managers established the Medical Committee. But in 2019, the legislature passed Senate Bill 1142, which allowed for the creation of the Medical Executive Board. So the Board of Managers created the Medical Executive Board, but they removed the Medical Committee. So we are adding that back into the bylaws because the Medical Committee is going to act as the liaison between the Medical Executive Board and the actual Board of Managers. And this is the language that's recommended for that particular section. So again, this is section 7.3 of Article 7. And then moving on down. And I'm sorry, my computer is just a little bit slower. There's another recommended change that we're making, and that's in section 9.2. And I'm sorry, can we go to 8.7? I apologize. Let's go to 8.7 first. 8.17. There we go. Thank you. So in section 8.117, we use the word inquiries, and we are making the recommendation that you change the inquiries to inquiries. So going from IN to the EN. And the reason being is that usually when you use the one with INQUIRIES, it's usually preferred for more formal requests and for official investigations. Whereas when you use the one with ENQUIRIES, it's more broader and it refers to any type of request. So that is a recommended change. And then I believe our last recommended change is in section 9.2. So when we look at section 9.2, this talks about an assistant administrator. You will see this term used in Article 3, and it is also used here in 9.2. Currently, Central Health does not have anyone here with the official job title of assistant administrator. However, you do have a deputy administrator. So the goal here is just to clarify who the assistant administrator is for Central Health, and that is the deputy administrator. So those are the changes that we have. David, I am going to turn it over to you. So if there's anything else that you'd like to add, and I will say that our team went through this as methodically as we could and tried to make these changes that needed to be done, and then just clear up some of the things that we thought needed to be cleared up in the bylaws. Go ahead, David.
No more substantive changes other than that. We do have some grammatical changes that we may clean up before we send out the final version of this, and we'll send it out to the full board and request that any board managers who have comments send them to Brianna, and she will get them to us. And if there are any, then we would add those in as placeholders until the full board can vote on it. And our plan is to just take it to the full board meeting in November, not as a consent item, but just as an agenda item, because these changes are very minimal, frankly, and just basically to bring it up to snuff. But welcome any comments or suggestions.
Yes, Manager Kitchen.
On the Budget and Finance Committee, is the treasurer the chair of the Budget and Finance Committee? Is that how it works?
Yes.
Under other parts of the bylaws?
Under the definition, under the treasurer's responsibilities, it's chair of the Budget and Finance Committee.
Okay.
Did I get that right?
There's
So
only,
this is
I did that off the top of
basically,
my head.
shall meet as deemed necessary by the chair of that committee. Okay.
I just wanted to know whether or not on page 1, under definitions also, talking about president and chief executive officer, that last line that uses the term administrator, should that be a capital A?
It's not capitalized in Chapter 281. That's the
Oh,
odd
so
thing. They
that's
don't
the reason
capitalize
we're-
terms
we're
of art in
forced to use
statute
a
in Texas. They just don't.
Lowercase.
They just
So the
don't.
administrator is a small a, and board member is a capital B and
It's-
an M.
It's defined, but it is little a in 281. I looked it up.
Okay, is that it? Do we have any other comments? Yes, Manager Jones.
So the copies that we have here are the edited ones, or the edits,
No.
those that you press there.
Steve, that's not the most up to date.
I apologize. We've been going through different versions of it, and we had another change that has since been dropped. So I am not 100% sure. May I borrow yours for just 2 seconds?
That has the past share stuff.
It does have the past year. So
Has the original bylaws, and then they have a copy of just the bylaws stapled together on their chair, but that's from earlier today.
this doesn't look like it's redlined at all.
Yeah, that one's not.
Oh, this is
They
just the
have-
original
they have a
what you
separate
have in the
stapled-
packet is just the original bylaws, sorry.
They have a separate stapled version of edited bylaws, but they're from earlier today.
And that has the past year.
Okay, thank you.
Yes, Dr. Bell had originally recommended something we were going to add in, and that has since been changed. Anyone else?
Yeah, one other comment.
Yes, sir.
Is this an appropriate time to talk about any addendums to the bylaws that we would like to make?
You mean red line revisions? Or I think
Yes,
that
sir.
Kind of implies you're going to add something.
No, an
completely
additional,
new.
I want to add something.
What would you like to add, Manager Jones?
I think that, and I think we've all discussed it, that the possibility of putting some kind of statement about time constraints for our deliberations, because I do think that there's a need for us to, and I don't know if the bylaws is the correct place to do it, but I do think we need to put some opportunity to be able to state that, so that everyone is on the same opinion and is operating under the same expectation. Over the next 4 days, we're going to be together like a family. Nothing's wrong with that. I just say that in the sense that I think after that, we're going to probably want to say, okay, henceforth, we're going to be, whenever we have meetings, we're going to have limit ourselves to a certain amount of time for dialogue and discussion. So I just raise this at this time. It doesn't have to be done now, but I just think that we as a board need, or future boards need to be given that
Cognizant.
opportunity. Yeah.
I think that in the past, what we have done is since the chair of each committee has been responsible for running the meeting, the chair would be responsible, I would think, and has done a relatively good job of monitoring and managing time. If you think that it requires something else, we can talk about that. And maybe set up a protocol or a practice. Yes, David?
Just to quote the bylaws, section 8.15, conduct of meetings. There is a section that states that the board wrote itself an exception to Robert's Rules of Order and said that the chair of any meeting may vote and establish time limits for discussion of each agenda item without the necessity of receiving a 2/3 vote of the board. That's an exception to Robert's Rules. You can do a simple majority vote, and the chair can set time limits for each agenda item. Just say, we're going to do
Right.
this much time. So there's already something in there.
No, but yeah, well, that's true, sir. Maybe that's something that each chair of every committee should be more cognizant of the time limitations, and that has been brought up by other members at different times, points in time. However, in light of the fact that we're going to be dealing with the process of looking for a CEO and new president for Central Health, I believe that we should be a little bit more lax in allowing our board members to pursue lines of questions with candidates, as that's going to be setting the tone for what happens at Central Health for the rest of their tenure.
Okay, I was just talking generically.
Yes, sir, I understand.
Not just for that, but, okay.
And your point is well taken. Thank you.
Chair,
Yes,
when you mentioned that
Manager Motwani.
being more lax with the sort of questioning and time during interviews as setting the tone.
As
Is that what we're
what
saying?
Dr. Bell will be doing.
No, but are you suggesting that being more lax with the time is setting a tone for what the future is going to be like? Is that what you said, or?
No, I was just wanting us to be cognizant of the fact that we're going to be dealing with a special situation. And I'm sure Dr. Bell is going to be taking all that in consideration and monitoring our comments and the time that will be used in the questioning of the candidates. But I'm sure that we all know that that's very important to make sure we get a full picture and understanding of what each candidate will bring to the table so that we can make a decision and vote.
Yes,
For the best
and at
candidate.
the beginning of our process, and we kind of talked about this last Monday, I guess.
Yes.
When we begin our interviews, we'll go over again at the very beginning the process. And so,
I think the concern is, oh, I'm sorry.
I'm just wondering if, are we not going to be able to set like kind of a pretty clear start and stop time for a job interview?
yeah, I mean,
Okay,
the
that's, I
inter-
just want to make
the
sure, yeah,
interviews-
thank you, that's good enough for me.
Yeah, okay, I'm sorry.
I didn't know if Manager
No,
Valdez
no.
was suggesting
The
that we
interviews
needed to
are-
extend that stuff or not, because I think that's
No,
not professional.
what I was assuming is that the chair, and in this case is going to be Manager Kitchen, would be doing a great job of making sure that time is limited to however much we're going to give the candidate and be able to vote, get a picture of the person. and
Yeah,
vote.
we can talk about it more next week,
During the
but
meeting.
there's an established, as you said,
Process.
Manager Motwani, there's a beginning and ending time for each person. And there's a set process for asking questions by the managers.
That's what I thought, thanks.
Yeah.
Is there anything else? Oh,
Want
yes,
to
Manager
emphasize,
Jones.
There may be a standard, there may be a process. The question is it enforced? And it's going to be up to the membership to see that it's enforced.
Yeah, and I will help do that as the chair of the
I'm not
session.
just talking about the nomination of the
Okay.
CEO. I'm talking about in general
During our board meetings.
Board meetings.
Okay,
And committee meetings. Yes, sir.
Yes, yes.
I get that.
I'm just making sure we said we're going to do something, let's do it. That's all I'm saying.
Anything else? Okay. Hearing no other comments, I guess one of the things that we're going to do next is look at confirming the next regular ad hoc policy and bylaws committee meeting date, time, and location. And since we don't know when we're really going to have a next meeting, what we're assuming is that during our board meeting on November the 15th of 2023 at 4 p.m. here at Central Health, 1111 East Cesar Chavez, Austin, Texas, 78702, then at that point in time, we'll be able to act on whatever revisions or suggestions you all have submitted to Brianna, and she will make sure that our Travis County attorneys incorporate that into the bylaws that we will be voting on at that time. Does anybody else have any other concerns? Okay, then at this time, I'm ready to accept a motion for adjournment. Manager Brisson.
That we adjourn the ad hoc policy and bylaws committee.
And I second it.
Okay, we have a motion by Manager Brinson. We have a second by Dr. Bell. All those in favor say aye.
Aye.
All those opposed? Any abstentions? Seeing none, motion passes. The meeting's over. Thank you.
Yep, you're on.
Hi everyone. We'll start in a few minutes. Let me just settle down. Thank
while we're sitting a few minutes, I guess I wanted to make sure that everyone knows that there's food
Next door.
next door. So,
Do you want to go grab it first?
There's barbecue.
it's up to you. I just wanted to let, I mean, we have a quorum, so they could go out when they wanted to.
So members, would you prefer to go grab food now? We have a long agenda, or as we go, so your preference.
I'm indifferent.
As you're eating.
With a plate in front of you, it's almost empty.
So would you like a 5-minute break, or should we move on?
I'm for moving on and
Okay,
Moving on.
as we need it.
thank you. Okay. Well, good afternoon, everyone. Today is October 25th, 2023, and it is 3:21 p.m. As a quorum of the committee is in attendance, I would like to call to order the meeting of the Central Health Budget and Finance Committee. As a reminder, some of our committee members may be also participating by video conference, so the staff will be managing video and audio feeds of all participants closely to make sure we have a legally compliant meeting at all times. The first item is public communication. Do we have anyone who signed up?
Yes, Madam Chair, we have two people signed up to speak.
Okay, great. So members of the public who wish to make comments virtually during the public communication portion of the meeting must have registered with Central Health via the online form or by telephone no later than 1:30 p.m. today. And we have two who signed up to make public comment. May you introduce them, please? Yes, no?
Yes, I will first read the guidelines for this meeting's public communication.
Thank you.
When called upon to speak, please introduce yourself by name before beginning your comments. Also, if your comments will focus on a specific item or issue on the agenda, please indicate the full item number after your introduction. Each speaker will be limited to 3 minutes. Staff will be timing each speaker and will announce when the speaker has reached their time limit to ensure the efficiency of the meeting. Once we have let speakers know they've reached their limit, we will allow 30 more seconds to wrap up their comments before they are muted. Due to the restrictions of the Open Meetings Act, the board may be restricted in discussing any items that are not listed on the agenda for this meeting. The board may choose to set aside any new issues for discussion at a future meeting. At this time, I will call on our first speaker, Mike Easlin.
Thank you, members. Mike Giesland, President and CEO of Central Health. It is my privilege to introduce Sharon Alvis. She is the new CEO for Sendero, and you'll be hearing from Sharon here shortly. And she's done a lot of things in her career, and I think if the Nobel Prize Committee had an award for compassion in insurance, she would be the sole finalist. And just an incredible executive leader. She is currently obviously Sendero CEO, but before that was at Curative Insurance Company, where she led some product and service line developments. And during her career, she's served in numerous management and executive positions in health plans, health systems, provider organizations, and on health plans in particular, and HMOs and Medicare Advantaged. And, which is an important, point to make as we think about the mission and role of Sendero in the community. Recently, I had the privilege of sitting down with her and just talking, and it was interesting. Sharon, you focused on two things. It was about collaboration within the enterprise, but also what do we do to improve health outcomes and tackle disease disparities, and what is it that we can do together as an enterprise to do more for the people that we serve. And so it wasn't, the conversation didn't quickly devolve into a bunch of insurance geekiness, which is typically what happens when you sit down with me, but it was really about the mission. What is it that we can do to make people's lives better? So again, it's my privilege to introduce Sharon, and again, you'll hear from her later on, but thank you all very much.
Thank you. And welcome.
Thank you, Mike. And at this time, I will call on our second and final speaker, Manager Cynthia Valadez.
I'm just going to take a a brief moment to thank our Travis County Commissioners for reappointing me to the Central Health Board of Managers yesterday unanimously. And I just wanted to tell all of you in our listening audience that Central Health continues to work on improving the quality of health for our entire community, but especially those that are our targeted population, those living under the 200% FPL poverty line. And we ask that you continue to participate, to let us know when there are concerns that you have, and let us know when we're doing a good job. We're not only here to criticize, or rather to comment constructively on what might be a better way of doing something, in your opinion, but also to listen to what our staff and board members think is the route that we should be going. And I want to thank Mike Giesland, and I want to thank the Central Health staff for having taken us down this path during Mike's last tenure, and his tenure with us during these last few years, and tell him that we appreciate everything he's done for Central Health and for us. It's been an educational experience, a good learning period, and we greatly appreciate his knowledge and his compassion and what he's brought to the table. I've never seen Central Health more active in reaching out to the population, to our residents, and meeting them where they are, as I have under your tenure, Mike. And I just wanted to thank you, and thank all of y'all as board members for being here in this position. Thank you.
Thank you.
May I ask the speaker a question?
Please.
Manager Valadez, I really appreciate what you shared, and I think a lot of us share that sentiment, especially as related to Mike and the team that he has coalesced and the work that that team has accomplished here. And since you've come to speak, and particularly on this matter around your reappointment, I am curious as to why you did not vote for our budget that and effectively the equity plan that we're working to advance this year.
I support the equity plan more than anybody. Well, not more than anybody, equally. My concern has always been, and continues to be, the $35 million that we give to the University of Texas for services that we're.
I'm
that are
sorry
not
to
being
interrupt, but we
provided.
shouldn't, in
Can
public
we-
comment, we shouldn't.
We're not.
Okay.
We shouldn't deliberate.
Sorry, Amit.
Debate back.
We can
sorry.
have an offline conversation
Okay,
about it. Thank you.
well,
Thank you.
as I'm going to take a moment as a prerogative of the chair to address something that, first of all, many of you may know I am a Palestinian American. I have family in Palestine, and I want to thank everyone who has reached out to me and my family. Your heartfelt messages have been felt, and I appreciate them very much. It's been very hard. It's just been very, very hard. It's witnessing the injustice that we experience, and now there's a lot of I know we're not, first of all, as a person who advocates for equity and justice, I'm in tremendous awe and pain as a public health person witnessing the issues that are confronting my people on a daily basis is heart-wrenching. And now, locally here, my community is experiencing a lot of hate, a lot of Islamophobia, a lot of anti-Palestinian, a lot of anti-Arab, a lot of anti things that we do not feel safe. We don't feel welcome. I urge you all to reach out to your community, to your neighbors, to your friends. We need you. As simple as a text can mean a lot. We are going through a lot, and my heart cannot handle any more pain. And I hope that we can all work to address this injustice and inequities and to know that people are grieving and dying, and more than half who have been killed are children. As a mom, this is unacceptable. So that's all I wanted to say. Thank you.
Madam
And
Chair, can you allow us a moment of silence in honor of those that are struggling in the world?
yes. Well, let's proceed. Item number 1, approve the minutes of the September 6, 2023 Budget and Finance Committee meeting. Do I have a motion?
I move that we approve the minutes of the September 6th,
Budget.
2023 Budget and Finance Committee meeting.
Thank you. Thank you. I have a first and I have a second. Do I, any discussion? All in favor?
Aye.
Motion passes. Item number 2, receive and discuss a presentation on community care health centers fiscal year 2024 budget. Jason Fournier and Joy Sloan will be presenting. Welcome.
Good afternoon, managers. It's our distinct pleasure to be here this afternoon. Except for present an overview. Okay, I'll start over. Good afternoon, Board of Managers. It's our distinct pleasure to be here with you this afternoon. I'm Jason Fournier. I'm the President and CEO for Central Texas Community Health Centers, and we do business as Community Care.
And I'm Joy Sloan, Chief Financial Officer.
So again, really appreciate the opportunity to provide an overview of our fiscal year 2023-24 budget for your awareness this afternoon. One of the things, our budget, similar to yours, begins on October 1st of each year and ends and concludes at the end of September. As always, our budget, just like Central Health, is really geared towards going ahead and making sure that folks within our community, within Travis County, and for us at Community Care, somewhat a little bit beyond, given our service area is federally approved by the Health Resources of Services Administration, which is part of the U.S. Department of Health and Human Services, that folks have access to the health care they need and deserve. As you know, our mission at Community Care is about strengthening the health and well-being of the communities we serve. Core to that is actually really, and if you want to break it down, it's not just about delivery of healthcare, it's trying to help individuals live longer and better lives. And the way we accomplish that is through direct service provision. And Central Health is an enterprise partner, as you very well know, but is critically important to our ability to do so. And so we're going to highlight within our budget the resources and investments that are being made by our peers here at Central Health and by you as the Board of Managers. And then we're going to talk also about our leveraged funding model that draws in significant resources to help the overall safety net here within Travis County at large and then beyond, and take a look at how those resources are being used to advantage. Our ultimate goal, with approval through our Board of Directors at Community Care, which is a majority of individuals that are patient consumers of the health center services that we operate in conjunction with you, are really geared towards addressing longstanding health disparities and getting at inequities that are persistent within our community. So not only is the direct provision of care important, but it's also recognizing that policy and other issues disadvantage our populations and really trying to gear our services to best meet those needs. What you're looking at is a slide from our services from 2022 as reported out through a report we provide to the Health Resources as a Service Administration each year, usually in February, finalized with the federal government, typically by April 1st. But you can see that in 2022, calendar year 2022, we served 129,005 unique individuals. It was the most patients ever. Actually, our data, preliminary data for the end of our fiscal year demonstrates that we're over 130,500 unique lives served last year. Our patient population is demonstrated by this graphic is very diverse, both from a racial and ethnic perspective. 87% of our patients served in 2022 self-report as being a racial minority or ethnic minority. 73% of our overall patient population self-report as being Latino. And when we take a look at around 13% white non-Latino, around 11 to 12% African American, and about 3% Asian American Pacific Islander. What's notable is 98% of our patients have incomes based on financial screening, reporting at or below 200% of the federal poverty level. For perspective, that means that for a family of four here in Travis County, they have incomes roughly of $58,800 and change in order to exist and to survive on. And so when we take a look at 200% is important to you as board of managers, that's the threshold you've set for services through the MAP Basic Medical Access Program Basic Program, as well as the Medical Access Program, which is up to 100%, depending on which cohort of patients covered through MAP are covered. There's alignment also. The 200% threshold is actually what we're required with Central Health as the applicant and Community Care as the co-applicant for the health center program funding. 200% is the target population. So our target population is 200% or below federal poverty and geographically defined. What's also notable on this particular, well, it's not on, yes, it is. It's on the slide. Is that 57.2% of our patients last year were best served in a language other than English. First language, of course, is Spanish. Second is English. To Manager Musaitiv's comments earlier, please know that we're very sensitive to the issues. Our third most spoken language is Arabic, and so many of the individuals you were speaking to earlier were very, very concerned about how folks are being treated within the community and mindful of that. So please know that your sentiments resonated with us very much. So number three is Arabic. Number four is Pashto, which is a language that's spoken in Afghanistan, and then Vietnamese is fifth. So a lot of diversity. By way of comparison, when you look at other health centers across the country, we're at 57.2% of our patients served in language other than English. The average health center across the country is at 24%. So there's a lot more linguistic diversity. What's most staggering when we compare ourselves to other health centers, and this speaks to our environment, not here in Travis County, but in Texas, a staggering 67% of our patients last year were uninsured. That compares to less than 14% across the country. And one of the biggest obstacles that we have here in challenges is the fact that we still lack a comprehensive Medicaid program that's directed to low-income uninsured adults. We do fairly well as it relates to prenatal patients as well as pediatrics, but that's an obstacle that we have. With that stated, even on the pediatric side, 17.8% of our patients last year, pediatric patients, were uninsured. That equates to what the average is, a little bit above what the average for uninsureds across the state is. So overall, 48% of the 129,000, or a little bit over 60,000 patients served last year were uninsured, many of which, 83% of those, are Travis County residents. That's why your support of our budget through the contract that we have formally articulated, which specifies the services, provides remuneration or reimbursement based on the level of services we're providing to MAP, or Medical Access Basic, Medical Access Program Basic, and MAP straight up patients is so important to us, and so we'll dive into that. If we can advance to the next slide, please. What you're going to see here is, just for perspective, is the service area that's federally approved by the Health Resources and Service Administration. And for your awareness, this is broken out at the federal level based on zip code tabulation areas, essentially zip codes, but it's the formal way of referring to the zip codes at the federal level. There's 55 zip codes, of which you can see almost all zip codes in Travis County are included. Some of the zip codes extend into Hayes and Caldwell because zip code tabulation areas don't respect county lines. They overlap, right? Same thing with 78663, which overlaps between Travis County and Williamson. And then we have several that reach out into Bastrop because we do have a Bastrop Women's Health Center that's been there for several years. What you're seeing on the left-hand side is the patients by concentration in zip code. So you can see our highest served zip code is our Runberg area, 78758. Over 13,000 patients drawn from that area. By way of perspective, there's over 26,000 unique individuals within that zip code that have incomes at or below 200% of federal poverty. So to normalize, because when you look, you see on the graphic on the left, a lot of that concentrated service is along the I-35 corridor, and then you can see going into eastern Travis County, formerly referred to as Eastern Crescent. On the right-hand side, what you're actually seeing is normalization of the population comparative to 200%. So the population we served normalized to the penetration within that area by a percent penetration. When we control for that, what you notice that lights up, the darker orange is in Colony Park, 78724. We have the highest concentration of patients from a percent basis served for those less than 200% in Colony Park. Over 80% of individuals less than 200% of federal poverty level in Colony Park are served by community care. That's a high level. By way of comparison, when you go back to 78753 Runberg, the penetration is between 40 to 60% based on the graphic we're representing. So it gives you a sense for, where are we actually having a direct impact based on the colors that are represented. And we'll have an opportunity to answer any questions you have. But this is just more so that you have awareness in terms of where services are, how are we doing, where are opportunities for improvements in terms of doing better by the individual communities within these zip codes. And we drill down functionally within our own tactical plans, strategic planning at census levels as well, because zip codes aren't always homogeneous in terms of, from an economic perspective and other perspective as well. So please, next slide. So some of the challenges as we move forward into, and there's a myriad of challenges being thrown at us. Probably the first and foremost that isn't indicated on here, but we always want to start with, the major challenge that we have in healthcare today is workforce. Workforce. It doesn't matter if we're talking community care, central health, one of the hospital partners in the area or across the country, community health centers post and other health systems post-COVID really saw significant challenges. We, like so many other industries, experienced the disruption that was caused through the Great Resignation. Some studies have demonstrated in 2022, 117,000 physicians left the medical claims system. They weren't providing claims like they were prior to COVID. So that's 117,000 physicians no longer providing direct care. What was surprising within the same study is that 58,000 nurse practitioners left as well. And some left to go ahead and become home visiting and to go into travel nursing because the money was too good to pass up. Some of those nurse practitioners are starting to come back, but there are challenges relative to workforce, but it doesn't extend just to providers, it extends to support staff. So Joy will talk a little bit about some of the changes, and you'll see some dynamics relative to our Medicaid population. But this last year translated for us into struggling to secure pediatricians, struggling to secure, and one that we're still struggling with today is dental hygienists. Anyone here know a dental hygienist? Send them our way. We're hiring always, right? Medical assistants, other folks like that as well. And so a lot of struggles there relative to, but we're doing well comparative to peers. So I don't want to paint this dire picture. We're faring better than the average health center. But with that stated, there's still, that to us is the number one challenge we have to meeting what your desires are, the desires in the community, and we're doing our very best with our partners, especially through the enterprise HR, human resources operations to go ahead and bolster what we're doing collectively. Another thing that continues to be a threat we communicated last year is relative to our pharmacy program. There are substantial challenges that continue to come our way. There haven't been dramatic changes, but if pharmaceutical manufacturers had their way, there would be significant changes. And that's as it relates to the 340B federal drug pricing program. For your awareness, this is a program that allows us to purchase medications on average between 35 to 55% below the average price that another pharmacy would be able to purchase, like CVS, Walgreens, Rite Aid, HEB, and then we pass those savings on to our patients. There's also the opportunity for revenues to be generated that come back to support us as a health center that advance the mission. And Congress, in their providing the 340B program to health centers back in 1992, recognized that it was a way to support the program. We're actually, as community health centers, the only one where it's articulated in statute that that's one of the main purposes. And so one of the risks is pharmaceutical manufacturers have tried to limit the number of contract pharmacies that should be allowable. And so there's been some restrictions in terms of what's going on. 2 years ago, we ended up with a net loss on one of our programs, close to $2 million, but we continue to buffer that by other expansions relative to our pharmacy services. So that's one we're following very closely. Another one, as I mentioned, was competition for talent, which is a workforce issue. And then one of the big ones this year is thanks to the prior administration and the current Biden administration, health centers really received, especially through the American Recovery Plan Act, significant funding to help recover from the COVID-19. And we had one of the largest awards across the country. By we, I mean us, Central Health and Community Care, as a health center program recipient, $30.7 million. That grant funding exhausts. We had an extension. It goes through the end of March. So there, within our budget is some of that funding that's helped bolster some positions. That funding ends for us at the end of March of 2024. So there's a hole there that's being filled, but it's being filled by other resources that we've leveraged in. And then the other one that's outstanding right now, we don't need to go into what's going into Washington. There's not enough time to talk about that from my perspective right now. But we currently are on a continued resolution relative to 70% of our overall grant funding, not just community care, but all roughly 1,400 health centers across the country serving 15,000 communities. And so Congress has to act in order to renew that. Probably the most notable thing, and Joy will touch upon this as well as she's reviewing some of the numbers, is as it relates to Medicaid redetermination. As you might already be aware, during the COVID-19 pandemic, the administrations went ahead and extended continuous benefits for Medicaid recipients. So, for example, here in the state of Texas, if you were a prenatal patient and you delivered your baby prior to COVID and post-COVID, now that this has ended, right, your benefits would have ended 6 weeks postpartum. I know the state legislatures passed legislation that allows it to go to 12 months, but that hasn't been approved yet by the Centers for Medicare and Medicaid Services. That analysis and waiver is still being pending their approval. So with that stated, women who were pregnant throughout the pandemic actually ended up with continuous Medicaid benefits. That ended on May 11th, and then there was redetermination. The first cohort of individuals that were determined to be ineligible were prenatal patients who were no longer pregnant and had gone past 6 weeks postnatal. And then individual kiddos who had aged out. Actually, what that means is they aged above the age of 18 and were no longer eligible for Medicaid. So there's been a substantive decrease in individuals who were otherwise covered through. So for example, one of our major plans that we participated, we're a large provider, as you know. We have roughly 30,000 individuals that were back in May, well, this time last year, 30,000 individuals that were enrolled in this plan and attributable to us. That now today is down to 23,000 and change. So we're seeing that dramatic. So there's implications because many of these folks were once covered through Medicaid, now are transitioning back to being uninsured, which means they're more than likely, if they're Travis County residents, because of their income levels, are going to need to be covered through the medical access program, right? And so there's been a buffer there for a couple of years. Next slide, please. So, as always with our board, we work very closely to align what we're doing, not just strategically. We have a strategic plan that's, of course, available through our website, and we shared some of that with you before, is we set organizational priorities each year based on some of the challenges and opportunities that we have. So one of the things is we want to make sure that we are considered to be an employer of choice. which means we're doing our very best to support those that support our patients. As you'll see, close to 63% of our overall budget is dedicated towards our employees and their benefits. When we include contractual labor, then that bumps up closer to 70%. Joy will touch upon that. One of the things that we're working very deliberately on is trying to make sure that we're increasing access, and specifically over this year, a priority on Travis County uninsured residents, so low-income uninsured residents. And that's mindful of some of the changes with the Medicaid redetermination. Informed resource usage is something that we want to always be data informed and making decisions given limited resource on how best to go ahead and meet needs, and then high quality care always. So I'm going to hand the mic over to Joy, and she's going to walk you through some of the financials. So Ms. Sloan, please.
Hi, good afternoon. So this slide really just kind of shows the growth from, I think it's 2000 and, what year is it? I can't read it. 21 to 24. And we have seen significant growth at community care, both on the revenue side and expense side in these last few years. We are anticipating fiscal year 24 to be about 510,000 patient encounters. We're ending this fiscal year at about 460,000 patient encounters. We are starting to see that demand come back post-COVID, which is a good thing. We are also at a point where we are able to hire and retain a lot of providers. So our pediatric program is now fully staffed on the medical side. We're working on the dental side, and our adult family medicine is getting there. So we're seeing some return of some good talent and the ability to retain. I will say part of our growth in the past couple of years has been heavily invested in staff wages in order to remain competitive. So I think we've put over $8 million into staff wage adjustments to try to bring them up to market and make sure that we're able to hire and retain quality staff. And that does kind of put pressure on the budget as we hit 24 and beyond, when we're starting to see some of those grant dollars that were invested into community health centers during the COVID years start to end. Next slide, please. This slide just graphically shows kind of the growth in expense and revenue and encounters year over year. And what it indicates is that expenses grew pretty significantly year over year without that same kind of increase in revenue. And we're starting to see those come back together now, where our expenses and revenue are kind of growing at about the same percentage. That does, again, put a lot of pressure onto operational efficiencies and revenue optimization in order to ensure that we are staying financially solvent going forward with the loss of those ARPA dollars and the increased competition for staffing. Next slide, please. So this is our fiscal year 24 budgeted revenue compared to our fiscal year 23 projection. We are budgeting about 210 million, almost 211 million in revenue for fiscal year 24. We're going to end about 128 million for fiscal year 23. So it's about a 6% growth in revenue. As Jason mentioned, we do feel the pinch of the Medicaid disenrollment, and you'll see Medicaid revenue is really projected to grow next year. And that is really related to the ability to hire and retain our pediatric providers, which in fiscal year 23, we were down quite a few for most of that year. So with the ability to hire and retain those providers next year, we do anticipate Medicaid rebounding a little bit. The other significant area of growth is in the Central Health Indigent Care Program, as we really anticipate a lot more access and infusion of MAP basic patients, and the growth that we're seeing in Del Valley and Hornsby Bend, the larger Pflugerville, Chalmers that we've opened recently. So, and then we've got additional access plans in the next year for additional care teams to help really meet that need. We are going to see a decline in our grant revenue as the ARPA grants go away by, as Jason mentioned, March of 2024. So that's factored in. So overall, patient services revenue is expected to grow about 18 million, while other revenue sources is expected to decline about 5.9 million. Next slide, please. When we look at the expenses, most of our investment is in wages and benefits. That's where we have the largest spend. We are anticipating that growth to be about 11% next year, as we are seeing our ability to hire and retain staff. I think in the last 6 months, we've been able to hire more people than we've lost, which is a very positive trend. We are expecting our contract labor to go down a little bit as we're able to move some of those people into employed positions and then not have to continue some contracted positions. And our direct care expenses are expected to climb a little bit. That's related to our pharmaceutical spend and the cost of the drugs to run the pharmaceutical program. So overall, operating expenses for fiscal year 24, about $210 million. So on an operational perspective, we've really kind of budgeted to break even. And when we look at all revenue and all expenses, that leaves us with about a $383,000 surplus for fiscal year 24. Next slide, please. So we wanted to really walk through the central health investment that is so critical to our success as a community health center. This is really the first one that I've worked at where we've had the support of a health district, and it definitely does allow us to do more than we could do without it in caring for our patients and offering more services. So we've seen a little bit of a shift this year in the contract with Central Health as we've moved more of the money into a fee-for-service category where we're actually going to get paid for what we're providing to direct care services for patients and a little less in community benefit support. And that was done in conjunction with our peers as we look at where we want care to go into the future and how we want to be able to account for it. And we are very excited to say that this is a significant increase in the contract year over year, 11.5%. We have to earn that. So there's a pressure on us to actually achieve and get those patients in the door. But that investment from Central Health is what really allows us to be able to hire and retain these staff and have the budget that we have this next year. And we translate that into about 271,000 encounters. That does include alternative visits as well as some specialty care as we move specialty more into the central health realm and kind of step out of some of that, and then a whole lot in medical, dental, and behavioral health services for next year. Anything you want to add to that, Jason?
No, I think the only thing to add, Joy, would be is so when you look at that bottom bullet on the key takeaways, one of the things is that as we've shifted around how the contract is arranged through our negotiations with Mike and John Morgan and others, the emphasis is on increasing services. So you see on a per accountable visit, there's a decrease, but the overall investment is substantially larger. But we're going from last year's budget, as you'll see, there's 2 extra slides at the back of the packet that we won't get into, but it dives into a little bit more. We had budgeted last year in 2023 for the fiscal year that just ended 186,000 visits on the direct medical, dental, behavioral health. Then there's alternative visits and some specialty visits that are additive that took that to 223. The year that we've just started, there's 217,000 direct primary care visits when we look at that for medical, dental, behavior. So you're going from 186 to 217. That's how we're making up and earning back some of the monies that have just shifted through these various different buckets for your awareness. So I think with that stated, you're up for the next slide, right, Joy?
Correct.
Great.
And then this slide really just shows an overview of Central Health's investment to our total expenses year over year, where Central Health was significant, covering the expenses of 64% back in fiscal year 2010. It's around 31% now for this fiscal year budget. That is still a significant investment, but it does show how we've been able to kind of keep Central Health's costs in line while serving more patients by leveraging other revenue sources. So in collaboration with you, we really want to bring in alternative sources of payment where we can so that we can make your dollars go further in serving the truly uninsured, most vulnerable within the community. And I feel like this slide really helps depict how successful we've been with that process.
And I think the other thing that's pointed out here, where there's some things that really impacted how the contract could be reviewed. We put in those boxes so that, there was a significant investment following the end of DSRIP in 2022 by Central Health, knowing that there was there was infrastructure that was built through the Delivery System Reform Incentive Payment Program that needed to be backfilled, and that occurred and then sustained. So the red line, you can see year-over-year percentage increase that Central Health has provided. One thing to note, if we look at the current budget year as being presented, 31.3% of our overall $210,500,000 budget is actually derived from Central Health source revenues. That's what's anticipated. But the level of services directed towards Central Health covered individuals is closer to 50%. So that demonstrates the leverage model overall in terms of there are resources that are drawn in to help to provide care to a greater number of Travis County residents beyond just what Central Health is funding. So that's the revenue optimization and diversification that's happened. Some of that is derived from pediatrics. It's derived from pharmacy services. So that's one of the unique things that we get to do as a health center and as your enterprise partners, in trying to make sure that we stretch the dollars very well. At the same time, very appreciative of the investment. So the next slide is just a question slide, right? So with that stated, we're happy, Manager or Chairperson Musa, to go ahead and answer any questions you and your peers may have this afternoon for us.
Thank you. Thank you, Jason. Thank you, Joy, for the presentation. I have a quick question. As your revenues decline, do you have any plans on how will you subsidize those in the future? So I just want to have, what's your backup plan that you're thinking of?
Well, we're not anticipating revenues to decline in the near term or even in the future years. Part of it is there's some inherent things that get bumped relative to our rates. It's usually based on the Centers for Medicare and Medicaid Services market basket. But with our negotiations with your team here at Central Health, we would similarly want to see increases year over year reflective of, cost of living adjustments, consumer price index, medical economic index, inflation. But one of the ways we do and can help with the revenue is to enter into value-based care. And that's something we are significantly starting to participate by. Of note, a collective group, a very large number of health centers across the state. There's 73 community health centers in the state of Texas. 49 came together earlier this year to form a new corporation underneath the Texas Association of Community Health Centers to form a clinically integrated network that allows us to jointly approach managed care organizations, Medicaid or otherwise, but we're going to start with Medicaid, to negotiate agreements that are value-based, that allow us to draw in additional resources to support the patient populations. They most likely won't be at risk anytime soon. They'll mostly be upside, but that's a future trend that we're engaged in and starting to participate in much more heavily, that will draw in additional revenues as well, at least from our Medicaid population. We also executed and we're one of the only health centers in the state of Texas to participate in the Centers for Medicare and Medicaid Services REACH program, which is an accountable care organization at the federal level that's specific to and provides advantages to value-based relationships. And in this case, rather than the typical fee-for-service, we're getting a global capitation primary care for a subset of our primary care Medicare population. And we're doing that in conjunction with another entity. We can't say who it is yet. That'll be forthcoming, still pending some approvals by the Centers for Medicare and Medicaid Services.
Well, thank you.
Great question.
Thank you
Yeah,
about
of
your
course.
future plans. Members, do you have any questions? Manager Kitchen?
Just a quick follow-up.
Thank you.
So are you receiving any kind of pay-for-performance kind of payments right now, incentive payments for meeting quality targets?
Yes, ma'am. So we have several, our contracts previously with Central Health had some of those for our MAP basic patients, but we do with our Medicaid managed care contracts and some Medicare Advantage contracts as well. And they're the typical P for P or pay for performance. You know, we had certain HEDIS measures for our Medicaid population. So looking at how many well visit checks have we done for less than 15-month-year-olds or 30-month-year-olds. And so those come into play for us. It's not huge overall, given our full spectrum, but that we're diving into that and have been involved with that overall. The value-based arrangements are really where we think there's more real money to come back in and leverage in to support our overall population.
So with Central Health, and I just don't, I'm not aware of this, or any of our contracts, pay for performance contracts at this point?
Within our existing agreement, I can speak to ours, I can't speak to other contracts.
Yeah, that's what I
Previously
meant.
or has been, but there is a portion of the agreement that hopefully will be executed here in the coming weeks that looks at an attributable population.
Okay.
And how we're managing that attributable population over the course of 18 months. And so that's something with Mike and the team support here that allows us to look more longitudinally on how we're engaging. As you know, Manager Kitchen, one of the good things or bad things, depending on your perspective in healthcare, is we are usually zeroing in or focused on 12 months.
Right.
And usually, and I think if we're really going to advance health equity from a population health perspective, we need to be looking at a much longer longitudinal perspective, ma'am.
Thank you.
Yeah, well, and also you provided the perspective of sharing in the cost, sharing in savings from reducing costs because of better quality and care is important. And so it sounds like that's something you're pursuing.
Yeah, we are absolutely interested in that, both through the Texas Association of Community Health Center clinically integrated network, as well as this other arrangement on the REACH program with CMS, and then other agreements as we start diving into them even further. We've had our eyes on this for some time. I would describe, for CommuniCare's perspective, that the Texas market has been more fledgling than other markets, and it's starting to be embraced partly because the state's asking for it. But we're going to find our way as individual providers as opposed to state mandates, unlike places like Oregon, California, and that have moved forward with this years ago.
Okay, at some point, not now, but at some point, it'd be interesting to understand from Central Health's perspective the extent to which we're doing those kinds of arrangements. So, okay.
Well noted. Thank you. Do we have any quick questions? Because we're running out of time. Yes, Manager Valdez.
This is just very quick. I didn't notice here on your, I'm sorry, thank you, Dr. Bell. I didn't notice here on your demographic information, are you seeing an increase in older patients that are not necessarily covered by Medicare due to whatever other issues that they may have to deal with, status, non-working, blah, blah, blah?
So so we'd have to go back, Manager Valdez, and to answer your question with concrete data to make sure that we're representing it. But I can tell you without a doubt, from a percent growth year over year, the fastest growing part, not from a sheer numbers, because it's a smaller part of our overall patient population, but from a percent year over year growth, our over 65 population has grown the fastest.
Okay.
It's upwards of close to 20%. I would assume within that are going to be folks that are not Medicare, but that's the part we'd have to go back with. And that's to Manager Musaitis' question earlier as it relates to growth. One of the things that we are looking at is how we better support an increase in aging populations. One of the reasons why, with your support here at Central Health, the Del Valley Clinic, we felt very important, given that there was a pharmacy desert there for many years, and there's a larger, older population that is in that area, especially down by Mustang Ridge, that we could be reaching out to provide better services to.
Thank you very much.
Yeah, thank you.
Thank you all. Any further questions? So with that, thank you, Jason. Thank you, Joy. Appreciate you, and thanks for that information.
Yes, thank you. Thanks for having us today.
Thank you. Now moving along to item number 3, receive updates on the preliminary September 2023 financial statements, including capital projects for Central Health and the Community Care Collaborative. Jeff Canoto and Patricia Bethke will be presenting. Welcome.
Thank you. Jeff Knodel, Chief Financial Officer, and Patty Bethke will be doing most of the Central Health presentation. I do want to kick off the Central Health September or financial statements as of September 30th. So these are our draft financial statements as of year end. It's still for year end early for us. So these are draft statements that we expect to have changes to as we start beginning to get into our audit process. But we thought it was important to bring to you what we have at this point. Just a couple of highlights. Year to date, our property tax revenue is at $280 million, which is comparing to $261 million last year. The important aspect of property tax revenue is what's the collection rate related to the tax levy, the adjusted levy. That part of it this year is lower than last year. The thing you want to keep in mind is there a change that you're not quite sure what's causing it? We think we know what's causing this, in the aspect of some legislative changes around property protest. So I'll leave it at that and move on quickly. Our healthcare delivery as of September 30th is at $181 million. Our LPPF balance is at $3.4 million. And then we have a couple of accounting standards. So there's always a dilemma of when you produce generally accepted accounting principle statements that sometimes you're not quite sure how they correlate, especially on the income statement. We implemented a lease implementation last year. This year there's a new one related to software subscriptions. It's not extremely impactful from a monetary standpoint. The lease portion that was implemented last year is, I feel like I'm getting feedback, but maybe it's just my ears. So related to our lease implementation of GASB 87, there is some significant increase, and then there's I'm going to say a current older reporting standard that requires you to mark your investments to market. And I don't know if y'all remember last year, but last year, because of increasing interest rates, we had a tremendous loss, and that's going to be standard for most governmental entities. This year, because interest rates have stabilized and gone up, we have a big what's called mark to market that reflects that increase in market value. The takeaway from all this is that they're fairly large entries, but they're not cash-based. They're at a certain point in time as of September 30th, and one way to look at it is, to some regards, they're just longer-term timing differences. So I'm going to turn it over to Patty to walk through the financial statements.
Good afternoon, managers. I'm Patty Bethke, Controller, Central Health and Community Care Clinics. On the balance sheet, I wanted you to note that we have a very strong cash position, about $508 million. With that, and our total current assets are sitting at $708 million, and our total capital assets are at $160 million. So our total assets year to date or as of September 30th, are $1.2 billion. In the liabilities, We are showing total current liabilities of about 30 million. So most of this is made up of the incurred but not reported for provider services, which we anticipate receiving invoices for in the near future. We have, as Jeff noted, we have funds held for the LPPF of $3.4 million. And in the debt service payable long term, that would reflect the COs that were issued, the 3 COs that we have outstanding. One of them issued this year. The total restricted or non-current liabilities are currently at 171 million. In the non-current liabilities, these are the ones related to the GASB 87 and 96 that Jeff mentioned. We have lease and subscription liabilities. The GASB 96 subscription liability is an increase of $4.6 million. So our total liabilities are at $490 million. In net assets, we're at $740 million of net assets. So that gives us liabilities and net assets of $1.2 billion. And moving on to the sources and uses. Our total property tax revenue, as Jeff noted, is at $280 million at 99% of the budget. Our lease revenue, this is where we reflect the revenue related to GASB 86, is at $19 million for the year. Do you want me to mention the amount?
No.
Okay. That includes interest related to the revenues received. And then in other revenue, the increase here, we're showing $46.6 million. The main portion of that is the mark-to-market adjustment for $24.5 million. And our total resources are currently at $351 million for the year. Moving to the uses of funds, we have spent $181 million for healthcare delivery program this year, and our administrative costs are at $18 million. This gives us total uses of $222 million for the year, and the excess of the sources over the uses is at $129 million year to date. On the next page, I wanted to focus on specialty care. On specialty care, we've provided approximately $15 million in specialty care services this year, and that's about a $6.5 million increase over the prior year. If you have any questions about the Central Health financials,
Well,
I'd be happy to
thank you. I like the inclusion of percent of budget used. I think that's great, and if we can continue on keeping that. Do I have any questions on Central Health's budget? Manager Kitchen.
If there's time. I just wanted to speak to the percent of budget used at this point. Can you just, I mean, we're not fully at the end of the year yet, but can you speak to why those, are we on track to, I guess we are, I'm sorry. Can you just speak to that column, the percent of budget used?
That is the year-to-date expenditures
Yeah.
compared to the budget. And
Yeah.
that's how much we've expended this year. And most, as Jeff noted, we're still working on the financial statements, so there's some additional estimates that we'll be doing that may impact those numbers.
But where do you, so can you tell yet where we'll be? Where are we going to be at 100% or over or under? Or?
No, as it relates to healthcare delivery specifically.
Yeah, that's
Yeah,
what.
no, I would expect there to be some additional accruals related to that, but I wouldn't expect it to change more than a couple of percentage points.
Okay.
Thank you.
Well, just very, very quick.
Yes, Manager Valdez.
The unrestricted funds on net assets. Thank you. The unrestricted funds, 467 plus or minus million. So that's available. It's not tied to any particular project or line of use?
Yeah, from an accounting standpoint, yes. It's not a capital asset, and on the restricted side, they're generally external type restrictions. So, yes, from an accounting standpoint, that's, again, how the accounting pronouncements look at net assets. That number's gonna be a little bit different than working capital, and we could probably use a session just to go over all of that, but we generally look at ending balance more from what's called a working capital perspective, which we're an enterprise fund, and that's generally the way that ending balances are calculated. So, so that's not, that number does not represent what we call ending balance. It's more of a accounting protocol on external restrictions or non-restricted.
Unrestricted. Okay, thank you very much.
Thank you. And I believe you still have the CCC?
Yes. Yeah, so I'll take that quickly. So just a couple of highlights as we wind down this Community Care Collaborative as of September 30th. Cash is a little bit over $104,000, and then liabilities are a little over $100,000, where you see net assets are slightly negative. We're still, again, these are draft statements. We're still working through the year end. I don't think there'll be substantial differences, but we need to work through this. Next slide. So on the balance sheet, you see cash and cash equivalents, and then accruals related to accounts payable, and again, net assets of negative a couple $1,000. Again, we need to work through final numbers, but I think eventually what you'll see is just the winding down of the Community Care Collaborative assets to the point where there'll be minimal amounts as of year end. Next slide. Just to walk through, most of these transactions occurred prior to September 30th. But you see for the year, we've recognized a little over $9 million in desert revenue, and that was, again, as the state concluded the desert projects, and we had a reserve for any potential recoupments that the audit process had. The audit has been completed through their third party, so we've recognized all of the reserve in desert revenue. That's a little over $9 million. And then you see total sources of 13.3, small amount of healthcare delivery, and then the partial payment of the affiliation agreement payment, and again, slightly negative net uses, net sources, overuses, or net assets. That's really the extent of the Community Care Collaborative financial statements as of September 30th. I'll be happy to answer any questions.
Thank you, appreciate it. Do we have any pressing questions?
Just
Quickly, yes.
when do we expect the CCC to be completely wound down? If it's going to be?
I don't know but you mean financially? Or?
Yes.
Well, financially, there are minimal assets in the fund. But if you're talking about non-financial, I can't really answer that question at this point.
Thank you.
Okay, well, thank you, Jeff. Thank you, Patty. Appreciate you all. Now moving on to item number 4. Discuss and take appropriate action on an update on Sendero Health Plan's financials and proposed fiscal year 2024 Central Health Funding Plan of certain Sendero Health Plans, claims, and administrative costs. For this item, Jeff Canodal, Sharon Alvis, and Ellie Bernache will be presenting in both open and closed session, but at this time, I announced that the committee is convening in closed session to discuss agenda item 4 under Texas Government Code 551.071, consultation with attorney, and Texas Government Code 551.085, Governing Board of Certain Providers of Healthcare Services. And it is October 25th, and it's 4:25 p.m. Thank you. Okay, hi everyone. It is October 25th, 2023, and it is 5:27, and we are on item number 4. At this time, I'm ready to entertain a motion. Manager Kitchen?
I move that the committee recommend that the board authorize the Central Health CEO and president to negotiate a financing agreement with Sendero for calendar year 2024 and future periods of CHAP high-risk program cost.
Thank you. Do I have a second?
I second it.
So I have a first by Manager Kitchen, a second by Manager Bell. Any discussion? So I'll have you, Mr. Kanoto, to present briefly. And
Thank you for
Thank you.
the brief promotion there. So quickly, this is a financing agreement related around our CHAP program, the high-risk program. It would be related around financing the claims cost and related administrative cost of the program. We will anticipate bringing terms back at the next meeting to seek approval of the Budget Finance Committee, and then ultimately we're requesting board approval. It's a financing agreement that would be triggered through a repayment, through the risk adjustment payment, through the CMS process, based on framework of triggering. And again, we're anticipating that the fund would be, or the agreement would be multi-year and would have some option periods related around the multi-year period. Thank you.
thank you, Mr. Kanoto. I do not see any questions further. So anything, board members? If not, are all in favor of the motion on the table? Mr.
Aye.
Manager Jones, any abstentions? So we have, can you please note, Manager Jones has abstained. So the motion carries. Thank you. Members, at this time, we'll move to item number 5, confirm the next Budget and Finance Committee meeting date and time and location. Managers, our next Central Health Budget and Finance Committee is tentatively scheduled for Wednesday, November 15th, 2024 at 4 p.m. at the Central Health Headquarters, 1111 East Cesar Chavez, Austin, Texas, 78702. I just want you all to know Dr. Bell will lead this meeting next month, as I will be out. And at this time, I'm ready to accept a motion for adjournment. So Manager Valdez moves to adjourn. A second. Manager Brinson, all in favor? Aye. We're adjourned. Thank you.
Okay, members. I expect this executive committee to run a little long because we've got one item that's going to involve discussion. But I have a plan so that if the discussion goes a little too long, we can stop the discussion but bring it back. So, with that, good afternoon. Today is October 25th, 2023, and it is 5:31 p.m. As a quorum of the committee is in attendance, I'd like to call to order the meeting of the Central Health Executive Committee. First item of business is public communication. We will receive public communication for both the Executive Committee and the Board of Managers meeting. Before we proceed to the Executive Committee meeting, members of the public who wish to make comments during the public communication portion of the meeting must have registered with Central Health via the online form or by telephone no later than 1:30 p.m. today. We do not have anyone registered to make comments, so we will now proceed to the Executive Committee agenda. Agenda item number 1, approve the minutes of the Central Health Executive Committee, September 6, 2023. Manager Valadez?
I move that we adopt those minutes.
Manager Musaiti?
I second.
I have a motion from Manager Valadez. I have a second from Manager Musaitif. Any further discussion? Hearing none, all in favor?
Aye.
Any opposed? Any abstaining? Motion carries. Item number 2, discuss and take the appropriate action on the process for the election of Central Health Board officers and form a special ad hoc committee pursuant to Section 1.1.1A of the Central Health Bylaws. Am I wrong, David?
7.1.1, sorry.
What did I say?
7.1.1 of the
Okay.
bylaws, sorry.
I'm going to just start again. Discuss and take appropriate action on the process for the election of the Central Health Board officers and form a special ad hoc committee pursuant to Section 7.1.1A of the Central Health Bylaws. Members, according to, and let me pull up my notes here. According to the bylaws, we set up an ad hoc nominating committee, and the committee is actually outlined in the bylaws as to who can be appointed to that committee. The only mandatory person to be appointed to that committee is myself. The others either can be not on the executive committee, and I think there's 2, and the other member besides myself is an executive committee member. So, hold on just a second. I should have put this in the 2 members from the executive committee will be myself and Madame Musaitif. The 2 members that are not on the executive committee will be Amit Matwani and Manager Martin. Okay, now, for the rest, now that the committee has been appointed, from now until the next meeting, we will be accepting nominations. Members can nominate themselves. Other members can nominate other members, but it's always nice to ask the other member before you nominate them. The nominating committee will then get together and hopefully develop a slate of officers that goes to the full board in December, and we vote. Now, if there are 2 members that want to run for the same office, we encourage you guys to work that out before determining who's going to be nominated. Because if we have to have a vote, it is an open vote. So people will see who people are voting for and who are not. Some people don't have a problem with that. Some people feel like that could be a big negative. So our tradition has been to sort of work out those issues prior to establishing the slate. And then we just have a slate of candidates that we put before the board. The board then takes action on that. And then those are the officers for 2024 and 2025. Okay? You can contact any of the nominating committee members. Doesn't have to be me. It can be Maram, could be Dr. Martin, could be Amit. Any of the members, you can call them, you can talk to them, you can send them an email. Be careful about the email thing. David gets real upset. Don't put too many members on there. It's got to be one-on-one. All right? So I think that's all I have to say about that. Dr. Martin?
Could you explain the board as a whole appoints the secretary?
Oh, the secretary is not an elected entity or position. It is actually separate. So we will have a slate of officers that will be the chair, vice chair, and treasurer. We will vote on that. Then the secretary will be voted on separately and will be appointed. Manager Ballard.
Clarification.
Yeah, this is open.
Clarification, Dr. Bill. You said the ability for nominations will go in until the next board meeting?
Yeah, till November.
Okay, so here it says November the 29th,
Right.
but it's not the 29th. Isn't our board meeting on the 15th?
Yes, that's right. And the reason I did the 29th, thank you for putting that in there, because now I remember what I wrote to you, Brianna. I thought it was too short, because our meeting in October was the last week of October, and the 15th, when our meeting is in November, gives us only about 2 weeks, and I think people need a little bit more time to think about it. You know, maybe Thanksgiving dinner will make you feel differently, you know, who knows. But in essence, come back to us after Thanksgiving. You're right, it's the 29th is the deadline. And then we vote on it in December.
Okay.
And we will have a nominating committee meeting prior to the board meeting.
That's right.
So that we can talk about the slate. And when is that nominating committee meeting? It's on the what?
December 6th.
December 6th, yeah. Manager Recite, do you have a question?
Do you have anything else that you want to add?
No, I'm really finished. I'm taking questions.
No, thank you.
Okay. All right. Thank you, members. And if you do have additional questions after you think about it, you can always contact me or any of the members, and we will attempt to answer your questions. That should take care of agenda item number 2. Agenda item number 3, review and provide direction to staff on the prioritization and tentative scheduling of items for consideration at future Central Health Board and committee meetings, including the board policy on vendor reports.
There
was
a motion on that item, sorry.
Oh, that's right. We have to create the committee. Thank you, sir. I do need a motion to create the special ad hoc committee. Manager Valadez?
I move that the committee approve the formation of a special ad hoc committee that our board, executive committee rather, approve the formation of a special ad hoc committee for the election of Central Health Board of Officers.
And do I have a second? I have a motion from Manager Valadez. I have a second from Manager Brinson. Any further discussion? And the one thing I want to sort of outline, which David actually schooled me on, is that in the bylaws, this does not have to be a recommendation to the full board. It is the executive committee that has the authority to create the nominating committee. So that's why we're not recommending to the full board. It's done here. All right. That being said, any further discussions or questions? Hearing none, all in favor? Aye. Any opposed? Any abstaining? Motion carries. Thank you, David, for reminding me of that. Agenda item number 3, review and provide direction to staff on the prioritization and tentative scheduling of items for consideration at future Central Health Board and committee meetings, including board policy on vendor reports. Brianna Yanis and Mike Giesland will be presenting.
Okay, I'll start by just going over the November tentative schedules. Starting with November 6th, we have an ad hoc appointments committee meeting. That's on a Monday. And at that meeting, we'll do the Sendero and Integral Care reappointment discussions with those members. Then we have strategic planning. On November 8th, we will have a CHIF update and then potentially a sobering center update. The Blackman's Clinic update will be moved to December. And we won't be having that ad hoc bylaws committee after all. And then budget and finance on November 15th, we'll have October financials, the Sendero budget approval and CUC and Sendero quarterly reports. And then executive committee, tentative schedules, approving the calendar year, that should say 2024 meeting dates. And then discuss research and survey reports in alignment with board responsibilities. And then for the board meeting, we'll have a public hearing on the LPPF for setting the FY24 rate. And then investments, approving the calendar, and the Sendero budget approval all on consent. And then an update from Travis County Investments and Markets and approve FY23 investment policy. And then an integral care update, which is tentative, and open government and conflict of interest training, HR state of the organization update, EEOC report, Brackenridge campus update, performance review update, and lawsuit updates. And that's all I have. I will pass it on to Mike.
Okay, Mike. Oh, I'm sorry. Was it Mike or Manager Kitchen?
Well,
Manager Kitchen.
yield to the board member.
I'm sorry, just a question. I'm not sure if this is appropriate here, but did you update folks on the succession committee meetings? And is that appropriate here, or do we do that someplace else?
Sure.
I didn't say that, but
Okay,
yes.
can you, do you have the dates, or do we need to ask Jeannie to come up?
For Monday and Tuesday?
Yeah.
Those are the
Yeah,
dates
but we
that
also
I
have some dates after that, tentative dates,
Okay.
so. Do you remember?
She said they don't.
We
don't
have dates blocked out.
We
but
have
we
the
don't-
first and second week of December blocked out.
Yeah, that's what I want to let people
Right.
know, is that we've got dates
Yeah,
blocked
the
out.
first and the second week of December.
Yes, that's correct.
Yeah, we have interviews on Monday and Tuesday.
Correct.
And so anyone on the board is invited to participate.
That's correct.
What that means, though, is that everyone needs to participate in all of it, full days Monday and Tuesday, because we're at the stage where it's initial interviews to then take to the next round of interviews. And the next round of interviews, I think, is tentatively blocked off for that first 2 weeks.
First 2 weeks of December.
Yeah, we don't have the dates yet.
Right.
But, okay, just wanted to let people
That's
know
great,
that.
that's great. Manager,
I just have a follow-up question. So we have Monday and Tuesday.
yes.
Have we have identified the number of candidates that we're going to have over those 2-day periods? Is that
That's
correct?
right.
So I guess my question is, are we not considering spacing them out so they won't have to be locked in 8 hours, 16 hours?
It's not an 8-hour day. It's the schedule, the agenda will be shared. Go ahead.
Monday starts at 8 and I believe ends at 1:30 or
Yeah.
I think it might be
3.
Yeah,
2
3.
hour interviews.
And then
Tuesday.
Tuesday starts at 10 and will end at 5.
Do we have individuals identified by time frames?
Yes.
Yeah, they sent an email.
Oh,
Yes.
well, I must have missed it.
I just sent it while you guys.
It hasn't been seen yet.
Yeah, but it doesn't have names. It just has
Okay.
Yeah.
the time.
Is there any reason we're starting at 8 o'clock on Monday?
I knew you was gonna ask that.
Well, we we're 8 on Monday, but Tuesday we don't start
It's
till
at
10.
10.
So,
We let you sleep in at 10 o'clock. Oh, till Tuesday.
Wednesday, Friday classes.
yeah.
Tuesday, Thursday.
Okay, I just raised the question.
Manager beside.
I have 2 things. I think I mentioned to you, November, I will not be able to attend meetings. Now, within those, you mentioned something, Manager Kitchen, in terms of the interviews. I will be traveling during that time. So you said to be in all or none? I just wanted
So,
clarification.
okay, so the first step is Monday,
Like if
Tuesday.
I call in, like for instance, if I have a free time and I call in for one interview, you do not want that? You don't?
No.
Okay,
So
it's good to know.
that's just for Monday and Tuesday.
Okay, I just wanted to know, just
Yeah.
to make sure that I'm following the protocol appropriately, and I respect that. Thank you.
It's to participate in all the interviews for that decision point, which is to take those, to decide who goes to the next level. Okay?
Okay.
So you can still participate in the next level even if you can't participate on this Monday and Tuesday.
So with that, I will not be able to join
Okay.
because of my limitation of
On
travel.
Monday and Tuesday?
Yes, I'm out at a conference.
Okay,
So just wanted to bring that up. Okay.
Can, Manager June, can we participate by Zoom?
Yes.
Did we set it up that way?
There is a link.
There is a link.
I just
There is a link, yeah.
need
But does that constitute
we-
full participation
Yeah,
or not?
I mean, from my perspective, it does. You just need to be
I'll
on
be
the
there
Zoom.
at 8 o'clock. I just want to make sure everybody says Zoom. Okay, thank you.
So thanks for that clarification.
But just so the members of the succession committee know, we have to have a quorum here.
Well, and also the candidates will be here.
Right. The
So-
candidates will be here and of the committee members. I don't know if you're on the committee. I don't think so. But the quorum, there has to be a quorum of the committee members present,
Present.
okay? And then those who are not committee members are welcome to join
Right.
via virtually, okay?
It's just,
And participate.
and participate, it's just gonna be harder to participate on Zoom because of the.
But you can listen in.
Yes.
Well, it's an active, it's not just a listening in. It's an active, there's, and then there's deliberation on Tuesday, so.
And Manager Kitchen, say for instance, I mean, I'm gonna be here, but say for instance, I was virtual, but I just wanted to listen. I didn't want
Oh,
to
I see
ask
what you're
any
saying.
questions.
As opposed to, is that what you mean?
Yeah, I just want.
Yeah,
Well,
I don't necessarily want to participate.
I think that's fine. I think what I'm thinking is that the deliberation of who, the decision-making about who goes from one step to the, has to be people that have been in both of them.
And so if I'm on and I listen,
Yeah.
I can still say, I heard his answers or I heard her answers and I thought they were really good or.
But you can't, you're not part of the vote to move them to the
No,
next.
it's just a succession committee that's. part of it.
Yeah, well, actually, the succession committee is gonna take into account everybody who was there for the
Opinion.
first 2 days
That's
that,
right.
that are is expressing an opinion. But if someone listens one day and not the next,
Oh, no.
then they're not part of the decision-making.
That's correct. And
Okay.
so I guess what I'm saying is that if I listen both days.
Yes,
Okay, then I can make comments based
Oh, yes.
on what I've heard.
yes.
Those will be considered and the succession committee will vote.
Yeah, and in fact, I suggest that if you're available to listen to all of them both days, you should be part of the conversation and asking questions.
And I agree with you, but
Okay.
there may be folks, if they're traveling or,
Okay.
whatever, and they're listening in, they may not be able to ask
Yeah,
questions.
well, I'm reluctant to have folks
Traveling.
who are not participating in the conversation be part of the decision-making.
Got
That's where I'm looking to my colleagues on the committee, if that makes sense to them.
That makes a lot of sense to me.
Okay.
I mean, just to manage the expectations anyway.
Yeah,
And it should be the case for any
yeah.
deliberation.
So you want? Yeah, and Maram, if you can sign in for some of it and listen, that's fine.
Okay, but I will not be part of deliberation. I will not make any comment. So understood, and I definitely agree and concur
Okay.
with that.
Okay?
Okay,
So who is the ad hoc committee on success? I wanna
it's,
make sure.
Manager Matwani, Manager Brinson, myself, and Manager Zamora.
Okay.
All right.
Isn't the chair an ex officio member of all committees?
I can appoint myself to make a quorum.
Okay,
So if a quorum is needed, then I can appoint myself and I become a quorum.
okay.
That's correct? All right. Now, Manager Valadez, there is an issue I think that you were concerned about, and let me get my thing here. Regarding the board policy on vendor reports. And what I would ask is that, first of all, you explain what board policy on vendor reports is, but then I think you have a request to add additional information. And could you also explain to us the reason for adding additional information?
I'm not quite remembering what I wrote, but if I'm not mistaken, I thought it would be important to note or to have clarified whether or not there's a conflict or duality issue. between any person from Central Health that is responsible for actually making a recommendation or approving the vendor's contract. If that made any sense to anyone.
Well, and
Just
the reason, well, the reason we send out, and Mike, and maybe David, can back me up here, but the reason we send out the list of contracts is for us to look down that list and determine if any of those entities
we have
a relationship.
Right.
And then we need to, each person needs to disclose that relationship. And I think we disclose it either to compliance officer or to the lawyers. Am I correct?
Either one is acceptable.
Either one.
Yes.
And once it's disclosed, then we get advice from them with regard to what steps we need to take to make sure that we're not voting or approving of something that deals with that vendor. Okay. And so, anything else?
No, I just wanted to make sure that that was the case. Thank you.
All right. Okay. Managers, do we have any other agenda items that we feel, oh, there is one that I have. The city, county, integral care, Central Health, am I missing somebody?
Dell.
Medical school, yeah, Dell Medical School. All met, and the city has proposed doing a study, audit, analysis. It's all over the place, but and looking at homelessness and determining the programs that are associated with homelessness in all of those different agencies. And then doing an analysis of how those programs intersect and where they intersect, but also where they don't intersect, and they may need to intersect. And so myself, Mr. Giesland, and Manager Kitchen received the scope of work. We've looked at it. We've given Mike and his staff our necessary recommendation for changes in that scope of work. There were some concerns about things that were in the scope of work that we may not need to be contributing money to look at. And so we plan to very diplomatically outline that for the city and hopefully be able to come up with a very, how should I say, expedited analysis or study or whatever we want to call it, and see if we can probably grab at some low-hanging fruit. Ange, you want to add anything?
Yeah, I would just add this is coming from some conversations that have happened over the last couple of months. The suggestion that that collaboration among all these entities would be useful. And so, because all these entities play some kind of role in serving the homeless population. And so, and they're all public entities. I mean, there's a lot of other entities in the community that serve the homeless individuals, but this is a focus on these public bodies. And so the goal is to understand what everybody's doing and see if there's room for collaboration where it hasn't already happened. And also to, well, that's basically it. So in the starting point is the thinking of, well, we need to somehow understand what everybody's doing. So sort of a first step, from my perspective, is almost like an inventory of what everybody's doing, which can then inform conversation.
And the reason I bring this up is because I would like for an agenda item to be placed on the agenda for December. All right? Because I think we'll have at least maybe, if nothing else, a short update
Yeah.
that we can give back to you guys and let you know where we are on that. Manager Valadez.
I'd like to know whether or not being in there, because I'm fully behind that. That should happen in everything, especially when it comes to healthcare, because that affects everything. You can't, if you're not healthy, you're sick, you can't go to work, you can't go to school, you can't do anything. There goes your family or yourself or whatever. But I'd like to also know the numbers of dollars that have been committed by those various agencies, because we've got lots of money, millions of dollars that has been appropriated by the city, by the county, blah, blah, blah. I'd like to know how much money has been appropriated and what has been accomplished with those dollars. Because if we have had, in other words, I'm looking for some fiscal and programmatic accountability.
Could I?
Yes, Manager.
So thank you.
Actually, Manager Kitchen, I'm sorry, the only purpose is to get something set for agenda. So
Oh,
under
okay.
551-042,
Sorry.
we're not supposed to
We can
deliberate
talk
it.
offline about
We're supposed
that.
to just
It's
tell the
not an
staff,
agenda
put it
item.
on the agenda.
Yeah, I
Sorry.
just wanted to make sure it
little
got
far
put on the
afield.
agenda for further discussion. And you can bring that up.
And y'all understood me.
Yeah, and you can bring that up when we have the full discussion.
Thank you.
Let's see, any other items? Okay, hearing none, I will go on to agenda item number 4, conduct the Central Health President and CEO exit interview. I announce that the committee is convening in closed session to discuss agenda item number 4 under the Texas Government Code Section 551.074 Personnel Matters and/or Texas Government Code 551.071 Consultation with Attorney. It is Wednesday, October the 25th, and it is 5:59 p.m. we are still in executive committee, and we have just come out of closed session. It is Wednesday, October the 25th at 7:02. We covered agenda item 3, and there was no motion, agenda item 4, and there was no motion necessary. Agenda item number 5, confirm the next regular executive committee meeting date, time, and location. Managers, our next Central Health Executive Committee meeting is tentatively scheduled for Wednesday, November the 15th, 2023 at 4 p.m. or immediately after the Budget and Finance Committee meeting at Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. Manager Musaitif moves for adjournment. Manager Valadez seconds. Any further discussion? Hearing none. All in favor? Any opposed? We are adjourned.
Thank you.
Managers, we will go rapidly into the Board of Managers meeting. Good evening. Today is October the 25th, 2023, and it is 7:03. As the quorum of the board is in attendance, I'd like to call to order the meeting of the Central Health Board of Managers. The first item of business will be the consent agenda. Members, no action is needed on item C3, as there was no recommendation from the Ad Hoc Succession Committee on that item, so it's been removed from the motion. Also, item C8 has been removed as the updated bylaws are not ready for the Board of Managers to review and approve, but we should expect that they will be in the next few weeks. Members, the Ad Hoc Succession Committee met this week and voted to move forward with interviews of candidates for the CEO position. Those interviews will be conducted in closed session during meetings of the committee next Monday and Tuesday mornings. You will all receive notice of those meetings and are welcome to attend. The consent agenda. C1, approve the minutes of the Central Health Board of Managers in August 30th, September 6th, and September 25th, 2023 meetings. C2, receive and ratify Central Health investments for September 2023. C4, approve the procedures and timelines to be used by the Appointments Committee to solicit, evaluate, and recommend candidates for new appointments and reappointments to outside boards and committees as discussed and amended in the Ad Hoc Appointments Committee. C5, approve the steps to be followed by the Appointments Committee to submit a recommendation to the Central Health Board of Managers for a candidate to be appointed to outside boards and committees as discussed and amended in the Ad Hoc Appointments Committee. C6, approve the minimal experience criteria of candidates being considered for new appointments as recommended by the Ad Hoc Appointments Committee. C7, approve action on an update on Sendero Health Plan's financials and proposed FY 2024 Central Health Funding Plan of certain Sendero Health Plan claims and administrative costs as recommended by the Budget and Finance Committees. I need a motion to approve consent agenda items C1, C2, and C4 through C7. Do I have a motion? I have a motion from Manager Jones. I have a second from Manager Martin. Any further discussion?
Just a very quick question.
Sure.
So if the public is wanting to understand the minimal experience criteria and the steps for the appointment, C5 and C6, where should they look?
Did we
Do
put
they
it
go
in the
back to the
packet?
committee, or where do they look?
Did we put the procedures in the packet or no? They're in the packet.
So-
So the procedures are in the packet.
Okay.
And so the public should be able to see those documents that we are approving under consent agenda.
Okay.
Manager Valadez.
I just wanted to know quickly if we have those appointments that are available, can we also put them on the website? Would they be on the website, or can we do that?
Appointments for?
For committees, or if we have any openings for the public to want to
Oh, yeah.
submit.
Yeah, and
Will
that's
those
part of
announcements
the
be on the
procedures.
committee? Will they be on our website?
Yeah, the announcement, what you're saying
Yes.
is a part of the procedure.
Okay,
And it will be on not just our website, but possibly other websites that
or affiliated.
we are trying to target or focus our recruitment toward that particular population.
Thank you.
Okay? Any further questions or discussion? Hearing none, I think I have a motion on the table. All in favor?
Aye.
Any opposed? Any abstaining? Motion carries. Yeah, but, show Manager Motwani as being absent, not voting.
And, Moran?
No, well, she's gone.
Oh, she's gone. She left?
Yeah, he's just out for a break. Okay, regular agenda item. Number 1, receive performance tracking plan and key performance indicators, KPI, as a part of the board-adopted healthcare equity implementation plan. Jeff Knodel and Monica.
And planning that has gone into the work that really brought us to today. So here is just the journey where Guidehouse came. We've been working with you, getting your feedback as we've designed this plan, now moving into implementation. But just to kind of speak to the breadth and depth of the work that's been completed, we looked at the community needs at a very granular level, identified projects that would have the most impact to address those needs. We modeled it. We looked at the implementation roadmap. So how are we going to execute in the most thoughtful way to meet the social and healthcare needs of our patients? And then we did the financial impact analysis to really understand what are the resources that are going to be required to effectively execute. The next slide, please. So as you can see, this process is important because it provided the structure and the guardrails to really go about this in a holistic, multidisciplinary, data-driven way so that we have the right information to execute at the right time and really engaging with our patients throughout this process. So as you will recall, when we looked at the community needs and really thought about what are the projects that are going to make the most impact, we solicited input from our patients and other community stakeholders to get their input as we designed the initiatives and then developed the operational roadmaps. So really tailoring this to patient preferences and local community dynamics. So here you're going to see, as we're standing up this high-performing delivery system across multiple care settings, the performance tracking as we move into implementation is so important. So when we think about the key performance indicators to monitor our performance, this will give us timely information as we monitor our progress towards these goals, and then also allow us to adjust in a timely way if our environment changes. Okay, next slide, please. Now I'm going to hand it off to Avi.
Thank you, Danielle. So in the next couple of slides, we'll walk through our rationale for why the KPIs were required, some of the guiding principles that were used in identifying those KPIs. We'll also walk through the system level KPIs, and I want to spend time on those because that's where the meat of the discussion lies. So as we started thinking about the KPIs, the first thing that we wanted to look at was this movement towards becoming a system of care, and the fact that a KPI should be able to gauge progress and performance at the system level was something that was paramount to us. We also wanted to look at KPIs from different clinical domain perspectives, and that was another thing that we specifically focused on. So some of the KPIs would be tracked at a specialty level, and there are KPIs who would also be looked at from different facility levels so that every facet of healthcare delivery is being tracked. We wanted to look at KPIs that were closer to things that were happening in the field, so KPIs that would have a direct impact on how our patients accessed care, what the quality of care were obviously prioritized. These are KPIs that are being recommended by key reporting agencies in the country, and most safety net systems are using KPIs that we have been recommending in our report. Now, another thing that we wanted to focus on was the anchor of all of our KPIs. That was the idea of health equity. So in our strategic plan, health equity is a central pillar, and we wanted to make sure that we have the ability to track various KPIs from the health equity lens as well. So these were the 6 guiding principles that we used when we thought about how we go through a long list of KPIs and identify the ones that are most valuable to us. Next slide, please. So another thing that I want to talk about is, yes, there is a long list of KPIs, but every KPI is not appropriate for every level. depending on the level at which an individual is in an organization, the KPIs that they should track changes, and the value of that KPI also changes depending on the level at which it is being tracked and reported. So what we've put forth in this pyramid is a very high level view of the different levels within an organization, and in this instance, the levels within Central Health. So if you think about an organization that provides direct care, well, the foundation of that is in the clinics, because that's where care is actually being delivered. So the foundational element of these KPIs lies in what a clinic manager or individuals who are leading various departments and specialties need to track. Now, if you think about how information gathered at that point would be escalated, service line leaders and divisional directors would need to know what's going on at the grassroots level. But the KPIs that would be valuable to them would overlap with what's valuable to the clinic managers, but there would also be some that would not be overlapping across those two levels. Above this would be the functional leaders, who would then be reporting to the executive team, and right at the top we have the board of managers. Now, a simplistic way of looking at these different levels is to think about an organization from the point of view of what an organization needs to do. When does that need to get done? Who actually does that, and how it actually gets done? So if you move from the top to the bottom, the what and how much time is spent on deciding the what decreases. So the board of managers should spend most of its time thinking about the what needs to get done. And as you go towards the bottom, the how, or the amount of time leaders spend on the how, needs to increase. So for clinic managers, it's actually how do we execute on the vision. And the executive team should focus most of its time on the what, the who, and the when. That's, again, an oversimplification, but just from the point of view of how roles and responsibilities need to cascade from the top down, the what, who, when, and how is a good rubric for us to look at this. Next slide, please. Now, when we thought about the KPIs that would really add value, we put those into 9 domains with one anchor. So what you see on the right-hand side in the text boxes are the domains, and there are 9 key domains here. So right at the top is access. Access has to be the first metric that gets tracked, because the idea and vision behind creating a system of care is to improve access for our patients. The second thing is quality. Now, oftentimes we've seen that capacity and quality are opposite sides of a scale. There are occasions when we've seen access being improved and quality being impacted detrimentally. And that's why quality needs to be tracked here. We cannot be at a point where we are improving access, opening clinics, but quality is decreasing across the system. The third is care coordination. What you see here is what the system of care is comprised of. And there are multiple cogs that need to work with one another. There is a likelihood of our patients falling through the cracks, and if we need to execute on the vision of truly becoming a system of care, care coordination metrics need to be tracked. So those are number 3 on the list. Patient experience. We need to make sure that our patients are getting culturally appropriate care, and for that we need to track how they are experiencing the system, because if they don't experience the system in the way they expect, they're not going to come back, and we need to make sure that we are retaining patients within the system. Volume metrics, these metrics tie directly with the capacity that we want to build over time. So number of visits, number of procedures, cumulative lengths of stay over a period of time are things that we want to track as we scale our system out. Labor metrics. Now, healthcare, again, the biggest cost for any healthcare organization is salaries across clinical and non-clinical disciplines. And we want to make sure that labor metrics, right from vacancies through to how we are recruiting folks, are being tracked so the system is kept efficient and working moving forward. Financial metrics. We went through the budget exercise, and financial metrics need to be tracked because there's a lot for us to do and not as much money. So making sure that whatever we are doing is fiscally responsible is going to be critical. And for that, tracking financial measures over an extended period of time is going to be important. IT and interoperability. So if you think about any healthcare organization, IT forms the backbone. A physician, a clinician sees a patient, and what do they do next? They put the information in an EMR, and that information flows through the system. So thinking about how we make sure that interoperability and IT systems are moving in the right direction and are in lockstep with our operational goals is going to be critical. So tracking IT and interoperability metrics is important for us. And last on this list is throughput. So thinking about how efficiently our system is working is going to be important because a healthcare system is like a funnel. We need to make sure that patients are moving through that system in clinically appropriate timeframes, and for that, benchmarking throughput both on a temporal basis as well as with similar organizations is critical. That's, again, a direct reflection of how efficiently our system is taking care of patients. Now, these 9 domains are anchored in health equity. What that means is for metrics where we can add equity as a slice, we are going to do that. So access is a good example. Tracking access globally is good because it tells you how efficient your system is, but tracking access at the demographic, economic, and social levels is even more important because our system is based on the idea of equity and we want to drive that forward. So again, you think about KPIs, it's the anchor and domain framework, with the anchor being health equity and the domains being the 9 that you see on the screen. Next slide, please.
Chair, I'm wondering if it makes sense to ask questions as we go along, or do you want to wait?
Because it's technical, yeah. If I see that we're getting a little too, sometimes when we ask questions, we get into.
Well, I was going to focus it on what was in front of us, but whatever.
That's fine. But when I see it, if I see us
Yeah.
wandering, I'm gonna
Sure.
say, I'm gonna go back to the
Well,
presentation.
it's up to you. I mean.
No, go ahead.
Okay. My question is about the 9 domains. I'm curious about what your thinking is about 2 different aspects that sometimes I see. And I'm not seeing here, so I want to ask you about that. So one of them has to do with the provider experience. So I'm not seeing that up there, and so what was y'all's thinking about that?
Provider experience per se.
Yeah, I would think of it as one of the domains, but was y'all's thinking that it wasn't, or?
So these measures are specific to what's included in the roadmap. And when we think about the roadmap and the initiatives, all of those are directed towards improving one or more of these. But provider experience, again, in today's world where there's limited provider availability and everybody's fighting for providers, I think that's another key measure that needs to be accounted for.
Yeah, I would think it, well, okay, so think about it, but to me, that's, how do we know it's working? The provider experience is part of how we know it's working. So anyway, so I just throw that out to, ask you guys to consider if that should be, I would include that as one of the domains. And then the last one is, and this may be inherent in another part of this, and that is, I assume by care coordination, you also mean case management or, yeah, okay. And then the last thing is the social factors. So, or some people call them social determinants of health. You have health equity there, but where does social determinants of health fit in here?
So health equity is the bucket where they fit, and the social determinants of health would be the different slices at which the domain measures would be reported.
Well, health equity and SDOH are not the same thing,
Yeah.
but you're including SDOH in the health equity bucket?
Yeah, so
Okay.
health equity is, again, the big bucket, but how do we actually track health equity is through looking at different KPIs, through the demographic, SDOH, and the clinical lenses.
Okay, it might be helpful to add that into.
Yeah, we can add it.
Because I didn't see it, and, okay,
Yeah.
thank you, all right.
One more question about that slide before we go on.
Very quick. I heard you say cultural, but cultural is not necessarily linguistic. So are we doing cultural and linguistic?
Yeah.
Okay, I just want to make sure that that's understood, because people will say, oh, well, you know.
Yeah, one of the key concepts in the equity plan is training physicians to deliver cultural and linguistically competent care. So it's not cultural only, it's cultural plus linguistic both.
For me, it's not only training, but it's having those people
Yeah.
that are culturally and linguistically appropriate for the populations that they're serving, the demographics that they're serving,
That's part of the.
all the way up and down,
Yeah.
for the service and the clinicians and the care transition teams, et cetera.
Yep.
Continue, please. Thank you.
Next slide, please. So this is the list of KPIs that we think is important for the board to gauge an idea of how the system is performing. Now, on the left-hand side is the domain, and all 9 domains are represented here. Then we have a list of KPIs, the different available cuts, and then the frequency at which those should be reported. So the first one here is related, the first 2 are related to access. Right at the top you have average days to next available patient appointment, and number 2 is same day access and after hours available visits that are filled. These are direct reflection of access to the system. Now, when we look at these, there are different slices at which we can, at which we have to look at these measures. Care type and clinics is just one of them, but we also need to look at them from the point of view of different SDOH related slices. So again, all of this is based in the idea of equity, and we use SDOH to delve deeper into how these things vary across different demographics, social, and economic cohorts. The second set is volume, so total outpatient visits and utilization per 1,000 enrolled. Those are a direct reflection of how much capacity a system is building over time. And the slices that we look at here are service line and provider type, and for utilization it goes beyond just those 2, and we also add clinics. But again, these are also going to be looked at from the demographic and the SDOH point of view, so that we can gauge how the idea of equity is being executed through our initiatives and is reflected through changes in these measures. And the next one is labor expense to target and vacancy rate. So again, HR and labor related measures. We have 3 financial measures that need to be tracked. The first one is total dollar amount for purchased services. The second is pharmacy expense, and the third is general clinical administrative cost. Quality, we pick diabetes and hypertension as the 2 that are more reflective of a broad cohort of folks. And that's why we think that it's important for us to track these. But again, the slices here would be demographic, geographic, and driven by other SDOH variables. For care coordination, the rate of 14-day transitional care management or primary care follow-up. And then the second one is rate of readmission post-discharge or admission to a post-acute care facility. The last one is patient experience, so patient satisfaction, and this would be done at the different clinics so that we can compare how our patients are experiencing different clinics. And Manager Valdez, to your idea, is culturally and linguistically competent care being delivered at those different clinics depending on the majority of patients that are seen at those clinics. So I know this is a lot. I'll take a pause here and take questions.
Manager Kitchen.
I a couple questions. So these are the ones that you're thinking in terms of report for the board. I'd be interested in seeing the whole set that you're talking about. Not that I totally agree with what you're saying, is that the board doesn't need to see all the KPIs and its different levels, but I'm just curious about what they are. So I'd like to see that. I'm also a bit reluctant to only look at diabetes and hypertension because I'm concerned about behavioral health. You know, I mean, that's a huge issue for a lot of our population. And so that is something that I would be interested. I'm sure you've got quality data somewhere in the system on behavioral health. So that would be important. And I see it by I'm sure you mean by population, because I'd want to know about drilling down to certain populations. So for example, at least right now, where we're starting to begin to focus on how we're working with the homeless population, I'd want to be able to understand what kind of KPIs we had that we could drill down to that population. So. And then the last thing is, it might be in your utilization per 1,000, but I think it'd be interesting to see potentially preventable ED visits and inpatient hospitalization, because that's a good measure of whether we're doing primary care appropriately. Okay.
Manager Valdez?
I know you're getting demographic and geographic information, but where the patient lives, where the patient is getting serviced, I'd like to know that, because that will tell me whether or not specific clinics and areas need to provide maybe varied services or different services or add a service or drop a service, because it's not necessarily being efficiently used or effectively used at that location. And especially where we're dealing with equity, I think that's an important gauge. And I'm sorry, I may have missed it. I'm sure it's here somewhere, but to me that would be an interesting aspect of I guess the appropriateness of clinic utilization by patients, where they live and where they're actually receiving services. And is it because that's where it's offered, or is that where they choose to go?
Yes, so, I agree. I think that needs to be reflected, and we actually had that analysis done when we were doing the needs assessment. So I think the infrastructure and the data connections are present, and I think that'll be important for us to track.
Just didn't want to be redundant. I didn't see it here, but you took care of it.
Okay. Any other questions? I think this is the last slide, so. Go ahead.
Next slide, please.
So really what we wanted to do here is just kind of wrap up. So really tying the KPIs to all of the great work that Central Health has completed over the past 2+ years. So again, just a culmination of the work, really helping to drive the success of your vision and to really execute on this high-performing delivery system across Travis County. Any other questions?
Any additional, Manager Valdez?
How are we going to gauge let's say we have 150, 175,000, 100,000 uninsured, not receiving services necessarily. in our area, how are we going to gauge whether we're making a difference in getting those people in our system?
Okay.
Because they're not in our system, so how are we gonna,
Right.
how are we gonna ever get them into our system, or?
Yeah, I think, so the first thing is so there's this inflection point where somebody goes to a clinic and hence becomes part of the system. And for individuals who are uninsured and were not part of the system, I think the eligibility point is where that needs to be captured. But what happens before that needs to be taken care of through outreach.
That's right.
Because if they're not part of the system and we don't know who they are, where they live, there's no way for us to track them, right? So the initial point of targeted outreach and bringing individuals to a point where they are aware of different access points and hence engage with the system to become part of the system through the eligibility process would be where those get captured and
Good evening, managers. I think that's a great question. That's one of the opportunities we have here with Central Health really stepping into the clinical space. As, for example, specialty care starts transitioning out of community care, they can increase access for primary care and really start expanding kind of their footprint in the building of clinics, in the building of services, in the unique, not that unique anymore, but the approach to dynamic access, which also touches on social determinants of health. So remote access, working on transportation, all of that, I think we can increase access and actually expand the population. All right. Thank you. Okay. Thank you. Manager Kitchen, please.
This is really good work. I really appreciate this work. I want to think about it a little bit more because I want to think about it from the perspective of what is the public want to see? What would be a meaningful measure for the public to see? I think you may have it here. I just want to think about that a little bit more. And then the last question is, are there going to be, what's the next step? Are there targets that will be set for each of the KPIs, or how is that?
So, yes, there would be targets.
Okay.
But, so where Central Health is right now is not comparable to where a lot of safety net systems are, right? We are just
Okay.
getting into direct care, or we just got into direct care and we are maturing. So wherever we have a commensurate system, we will identify targets. But the bigger thing is the temporality of these measures and how they track over a period of time. So we need to do that for every single measure. But for ones where we don't have a comparable system, I don't personally think it's prudent to put KPIs. But a lot of these measures would be amenable to identifying benchmarks just because there are other systems who can be compared to what Central Health is doing right now.
So we might have benchmarks related back to where the community's at right now?
Yep.
Because it's like on the, it would seem, yeah, so it would seem to me that maybe what we would want is to know where the community is. Maybe we haven't set the target about where we want to be, but we want to see that we're moving the ball on where
Yes.
the community is right now.
Yep.
Is that what you're saying?
Yes, and in the strategic plan, we have targets, right? So it's 50%. Again, I'm just giving an example, but it's you go from where you are now to meeting 50% of community need over X years, and then it goes to 70% and 80% over X plus 1, X plus 2 years. So that's part of the strategic plan that was created last year.
Okay. So the other question I have is, when does this start? Is that, I mean, Mike, maybe that's a question for you. When do these start for the board? Or maybe y'all haven't figured that out yet?
Well, I'd have to defer to some of the folks in healthcare delivery and strategy on this, but
Okay.
I think, one, getting them out there, but then two, there's lining up the compilation process to be able to start reporting on these. And so I think
I'm sure it'll take a
they
while.
can start tonight, obviously, but then it's, when do you start seeing the report, the
Yeah,
actual
that's what I meant.
reporting? Okay.
Yeah,
understood.
that's what I meant.
Yeah,
When,
I'll defer to
because I
my
see
colleagues
the
on that one.
monthly and the quarterly and that sort of thing, but
When's the first report come in?
6 months, a year,
Yeah,
I mean, how long will it take?
I think some of it is going to depend on how we're slicing it.
Okay.
I think, and I'm going to hand it to John and Alan for the ones that we're slicing based on our own direct service delivery that we're providing the clinical services. A lot of these measures are measures that you have seen in different formats based on services that we're contracting for already. Manager Valadez, I think when you look at, where do people live and where are they getting services, we look at that in the demographic report every other year now. I think so some of these things, it's pulling them into this format and tracking them. I think I could confidently say that we'll be reporting on a subset of them probably by the end of Q2. So, and then maybe take the year together, the, kind of the full complement, at least our full baseline, baseline year.
I think all I would add to that, Manager Kitchen, is some of these metrics we cannot measure today.
Yeah,
So I think there's
that's right.
some work that has to be done infrastructure-wise, also with our partners in the healthcare system. Some of these measures, we don't receive the data that we need to measure them. So it's going to be an ongoing process, but we didn't want to design the KPIs for what we were trying to implement just around data and reports that we have today. So some of this is a little aspirational, and we're going to have to work with others to pull it all together. Yep.
Manager Valadez? Oh, wait a minute.
One of the items, am I on?
Yeah, you're on.
One of the items I was hoping to touch on is, Manager Kitchen, you asked about behavioral health. I think what we were hoping to do is spend a little bit of time on each metric and then rotate metrics.
Okay.
So that over kind of a longitudinal time period, you actually have a snapshot of different aspects. And some of the metrics are going to be specific to our own clinical practice. And then, John and Monica touched on these, hypertension and diabetes is really, we will play a role, but it'll really be specific to partners and as far as the hospital district. And so it'll take time for us to show that, show the benchmark, what exists within the safety net, where are we, what are our hopes, and then we'll rotate metrics over time.
Manager Valadez?
As we were talking in terms of these are systems that we're developing, we have such we all know and acknowledge transportation is a big issue. And we do not have pharmacies. We do not have places where people can go to, food deserts, where they can go buy healthy food. So as we move our services to those deserts, are we going to be connecting the systems, working with, let's say, Capital Metro, or working with, is someone going to be working with the entity, maybe putting a component in for pharmacy to be open while the clinic hours are open in an area where no pharmacy exists, those kinds of things. Because especially as I look at the day, then I look at the month, and I look at the year or the week, and you may have people on a weekend, and there's nothing open on a weekend, and they may have a transportation issue, and, they don't even get a bus system because it doesn't go outside, the boundaries of the city limits, or they have their set area to go, so. And that takes a long time, but we've been working on that for a long time. Well, at least a few years.
Yes, and I think those are all great great points to identify, whether it's transportation or pharmacy or others, food. Those are all areas where we have done work. That work is ongoing, but some of those connecting services and even some of the centralized navigation is part of what's built into the plan. Those are initiatives. Our navigation center just turned on, a couple of months ago, but it already includes some centralized transportation resources, whether it's rideshare or taxi or bus passes or specialized transport for wheelchairs and stretcher transport. So we have those resources today. I think we want to grow what we're doing and apply it to different areas. And to Alan's point, not just our direct practice, but make sure that those resources cover the healthcare district and our partner services as well. Pharmacy is going to continue to be a big part of our strategy. You heard about that a little bit earlier today from community care. As we are building new services, new sites, pharmacy is a critical component of it, including building pharmacy services that are integrated with those clinic services and hopefully filling some of those gaps in the community.
So I know in poverty populations, what you'll find is a lot of children alone after school. That doesn't go away. It just seems to increase the further out you go because we're talking about a transient population. And the same thing on the opposite end, where you have poor seniors that are only living on a social security system whereby they're getting $600 a month from 40, 30, 20 years ago, and they can't live in this day and age on that with barriers that they're having to overcome. They can't overcome those barriers. So at some point in time, excuse me, we may have to build up a system that doesn't yet exist for communicating and connecting those members of the population and the communities, those specific communities, with our systems to better care for the total model community that we're trying to create.
Okay. But any other?
Dr. Bell, if I may, in response to Manager Valdez's
Go ahead.
question and to tack on to what has previously been said, that's one of the strengths of a key performance indicator is that if it's on the low end of the range, and let's just take controlling diabetes and quality, they're about 2/3 of the way down this list. If you get an unfavorable reading, it starts to beg the question why. And so you may have all the clinical teams in place and all the front office and back office things in place, but back to the food desert, you quickly realize we've got to find a way to close that gap right there. And so that indicator, I think, prompts that level of inquiry to be able to answer that so that you can reallocate the resources as necessary.
Thank you. Thank you, sir. Anything else? Thank you guys so much. Appreciate the information. Excellent job. Excellent job. Okay, we are now going to agenda item number 2. Receive and discuss an update on Central Health and Integral Care collaboration. Mike Giesland and Jonathan Morgan will be presenting briefly in open session. Members, if you have questions regarding this item, please wait until we go into closed session for those questions. Okay?
Yes. Thank you, members. I will quickly summarize just where I think we are. We've prepared an addendum to an existing contract. I think that expedites this process. And currently, Integral Care has that addendum. I was advised earlier today that it is under review by their legal counsel at this point. I don't want to speak for Integral Care, but at this point, we haven't received any major requests for changes or inquiries or having any indications that there's a problem with this. But I want to give them the space to let their counsel look at it and come back and say, hey, we need to change these provisions in here. But that is where we are. And then again, because this is an addendum to an existing contract, once we get a signature on it, which I'm authorized to do, we can get implementing this rather quickly. John, is there anything else that I've missed in this?
No, it's been a very collaborative and I think quick process with the Integral Care team and their leadership to put this together. I think, after the budget was adopted and the tax rate, we came together pretty quickly, had 3 or 4 meetings and a few other phone calls on top of that, and first came up with a reimbursement methodology and structure, and then had a little back and forth on rates and what was appropriate, what covered their internal costs associated with different services. But I think to a large extent, the $7 million that we would be adding to this agreement will cover the span of outpatient services that Integral Care provides for our patient population here in Travis County. So it's a combination of psychiatric services, behavioral health intakes, a lot of case management, and adjunct services that they provide, as well as some behavioral health counseling. So happy to answer questions in closed session on this.
Okay, thank you guys very much. We appreciate that. Agenda item number 4, please discuss updates on matters related to a performance review contracted by Travis County, including delegations to the President and CEO to execute necessary agreements between Central Health and Travis County and Mazars USA. Mike Giesland, Monica Crowley, and Jeff Canodal will be presenting.
So can I ask a question? So are we gonna go into executive session? Because I'm.
Yes.
Okay,
But
After we
these
go through all
these parts are in open.
gotcha.
And then, once we have the presentation in open, then I'm going into executive. And I'll call these agenda items to go into executive session so that we can talk about them. Okay? Mr. Giesen?
Yes, so under agenda item 4 on the performance review with Mazars, I'm sure we've told you before, and I'll reiterate this. We have weekly meetings with Mazars. We have a team that's set up here internally. Jeff and Monica are the executive sponsors of that team. Katie Coburn is managing that team for us. And I've personally been on those conversations, and there's been really a good dialogue, and they're really trying to make sure that they ask for everything that they need, but also understand what they're asking for as well. And so it's at the point right now where information is flowing. We've got a secure file transfer set up to where we can push a lot of data and a lot of documents in there. Think of it like a big room with shelves on the wall, and so they can go pick and choose, what it is that they need to be able to conduct their review. We have not gotten any questions, maybe, deeper inquiry, like, okay, you've shown us this document, or you provided this to us, or we've got access to this database or this data set, now help us navigate. We haven't even gotten to that point yet. So I think they're just in there looking around and pulling things off the shelf, if I could stick with that library metaphor, and starting to look through the information. But that's essentially where we are at this point.
All right, thank you, Mr. Giesland. Anything, Jeff, Monica? All right. I would now like to go into closed session. I'm going to read items 3, 5, and 6. Item number 3, discuss and take appropriate action on Central Health owned and occupied real property and potential property for acquisition, lease, or development in Travis County, including pending issues and next steps in the redevelopment of the Central Health downtown campus, administrative offices of the Central Health Enterprise Partners, and new developments in eastern Travis County. Agenda item number 5. Receive and discuss briefing regarding Travis County Healthcare District, DBA Central Health versus Ascension, Texas, FKA, Seton Healthcare Family, cause number D1-GN-23-000398. And agenda item number 6, receive and discuss a briefing regarding Birch et al. Versus Travis County Healthcare District, DBA Central Health, and Mike Giesland, cause number D1-GN-17005-824 in the 345th District Court of Travis County. I now announce that we will be going into closed session. It is October the 20th. attorney. And item 3, under Texas Government Code Section 551.071, consultation with attorney, and Texas Government Code Section 551.072, deliberation regarding real property. Again, it is October the 25th, Wednesday at 7:57. Ready? Okay. We are out of closed session. It is Wednesday, October the 25th, 8:23 p.m. Within item number 3, I'd like to accept a motion from Dr. Brinson.
I move that the board delegate authority to the president and CEO to execute a lease on terms similar to or better than as presented by staff in closed session.
I have a motion from Manager Brinson. I have a second from Manager Valadez. Any further discussion? Hearing none. All in favor?
Aye.
Any opposed? Any abstaining? Motion carries unanimously. Thank you, members. And agenda item number 7, confirm the next regular board meeting time, date, and location. Managers, our next Central Health Board of Managers meeting is tentatively scheduled for Wednesday, November the 15th, 2023 at 4 p.m. at Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. Manager Valadez moves adjournment. Manager Matwani seconds. Any further discussion? Hearing none. All in favor?
Aye.
Any opposed? Any abstaining? We are adjourned.